Welcome to this explainer. Today, we're diving right into what is truly a monumental paradigm shift in modern medicine. For decades, our approach to Alzheimer's disease has basically been guessing at a diagnosis based on symptoms and then just kind of managing the inevitable decline. But today, we're crossing a massive threshold. We are officially moving from guessing and managing to biologically confirming and actively modifying the disease itself. Because the biological reality is that Alzheimer's doesn't just start when you forget where you put your keys. The underlying pathology, specifically the buildup of amyloid plaques and tau tangles in the brain, actually kicks off 10 to 20 years before any noticeable cognitive symptoms even appear. Recognizing this massive unseen window is literally driving the entire revolution in how we approach the disease in 2026. We're not just looking at the end stage anymore. We're finally looking at the biological beginning. So, here's our roadmap for today. We're going to start with the new diagnostic era. Take a look at the anti-amyloid vanguard, understand the very real risks of ARIA, explore neuroinflammation, and finally, peek into the future of combination therapy. Let's get right into it. Part 1. A new diagnostic era. Moving from symptom-based guesses straight to biomarker confirmation. Now, how does diagnosis actually work today? Well, it happens in layers. It starts with your standard bedside cognitive screening. But step 2 is the absolute game changer: blood-based biomarkers. We actually have FDA-cleared tests now that look for specific Alzheimer's proteins right in a regular blood draw to help rule out amyloid pathology. And then step 3 brings it all together, relying on mandatory PET imaging or spinal fluid analysis to biologically confirm the disease before any treatment even begins. Which brings us to part 2, the anti-amyloid vanguard, the very first wave of biological treatments. Right now, we've got 2 absolute heavyweight treatments leading the charge here. First up is Leqembi, which acts as a continuous maintenance therapy. It targets amyloid protofibrils to stop those plaques before they can even fully form. And contrasting that, we have Kisunla, which is a finite treatment. It goes after the already formed plaques. And what's wild is that once a PET scan shows the amyloid is cleared, patients can actually stop their IV treatments. But the big question you're probably asking is, do these drugs actually work? Well, recent 4-year data for Leqembi shows a 9.8-month delay in cognitive decline. And for patients who are caught in the very early stages, over 70% of them showed no measurable decline over those 4 years. They just remained stable. That is an absolute breakthrough for families facing this diagnosis. But we absolutely have to look at both sides objectively here. While a ton of experts are celebrating these drugs, a massive April 2026 Cochrane systematic review analyzed data across this entire class of medications and actually concluded that they probably result in little to no difference in cognitive function. They even labeled the clinical benefits as trivial. Now, this has obviously sparked a massive debate in the medical community. Proponents argue that the review unfairly pooled older, failed drugs with these newer, much more effective ones. But regardless of where you stand, it highlights a crucial reality. These drugs are not cures. They offer a modest slowing of decline, not a magical reversal of memory loss. And balancing those modest benefits leads us to part 3, understanding ARIA, the sobering reality of amyloid-related imaging abnormalities. Think about this. There's roughly a 21% combined risk of developing a condition known as ARIA when taking Leqembi. And for Kisunla, depending on the titration schedule, it can actually be even higher. So this is a very serious reality that requires incredibly careful consideration before anyone starts therapy. To keep patients safe, we really need to define exactly what this threat is. ARIA basically comes in 2 forms. You have ARIA E, which is brain swelling or edema, and then you have ARIA H, which involves microhemorrhages or tiny bleeding events inside the brain. Now, most of the time, ARIA is totally asymptomatic, but it can cause focal neurologic deficits that mimic a stroke, and in some rare cases, it can be fatal. This is exactly why strict MRI monitoring is absolutely mandatory. If you're on Leqembi, you have to get MRI scans before the 3rd, 5th, 7th, and 14th drug infusions, specifically to catch any of this swelling or bleeding early on. And because of these severe risks, genetic testing is completely non-negotiable today. The FDA explicitly warns that patients who are ApoE4 homozygotes, meaning they inherited the Alzheimer's risk gene from both parents, face a significantly higher incidence of symptomatic and serious ARI compared to known carriers. Testing for this genetic status is highly recommended before starting treatment, just so patients fully understand their individual risk profile. Okay, let's shift gears to part 4, targeting neuroinflammation, the dual nature of microglia. So let's talk about microglia, because they have this incredibly fascinating dual nature. Under normal circumstances, they are your brain's microscopic protectors. They roam around, they clear out cellular debris, they support healthy synapses. It's great. But when they are continuously exposed to amyloid plaques, they get overactivated. They physically change their shape and their function, essentially kicking off a self-destructive inflammatory loop. Instead of protecting the brain, they start dumping these toxic pro-inflammatory cytokines that actually cause synapse loss and neuronal death. So they literally turn from protectors into destroyers. So to win the fight against neuroinflammation, we basically have to figure out how to calm these angry cells down. And that's led to some amazing innovative drugs like NTRX-07. This is a selective CB2 receptor agonist. In simple terms, it's a biological switch. It binds to those overactivated microglia and shifts them from that toxic pro-inflammatory state right back to a protective anti-inflammatory state. And in animal models, this didn't just decrease inflammation, it actually restored synaptic plasticity and memory function. Which perfectly sets up Part 5, the future. Next-generation precision medicine through combination therapy. Looking at our future arsenal, we're targeting 3 incredibly distinct areas. You have trontinemab, which attacks amyloid, but uses this brilliant brain shuttle delivery system to cross the blood-brain barrier 50 times more efficiently, giving us a 91% clearance rate with minimal area risk. Then there's bepranemab, which directly targets those toxic tau tangles, making it the very first anti-tau therapy to show a clinical signal in actually slowing cognitive decline. And of course, NTRX-07, which focuses entirely on taming that runaway neuroinflammation. Ultimately, experts across the board, like the advisory board over at Mount Sinai, are completely aligned on this. Think about it. We don't treat cardiovascular disease with just a single pill, right? We use statins, antihypertensives, blood thinners, all working together. Well, defeating Alzheimer's is going to require the exact same approach, a tailored cocktail of therapies. We're going to need to clear the amyloid, stop the tau tangles, and calm the immune system, hitting all of these biological pathways at the exact same time. Which really brings us to the ultimate question for today. We have finally transitioned from blind symptom management to highly specific biomarker confirmation. We're actively clearing plaques, we're figuring out how to tame brain inflammation, and we're building shuttle systems to safely deliver drugs right past the blood-brain barrier. So, as we watch this incredible era of precision medicine unfold right in front of us, I want to leave you with one final, provocative thought to chew on. Are we finally witnessing the beginning of the end for Alzheimer's disease?